Good morning. Hopefully you can all hear me. Yeah. It's a pleasure to be here today. For the next few minutes, we'll focus our attention on prevention of chronic conditions in women and how to address research gaps in this area. Next slide. Research to date has shown that screening and prevention reduce risks for chronic conditions common in women. These include breast, cervical, colorectal, and lung cancer screening, cardiovascular disease screening and prevention, screening for depression and anxiety, diabetes, and osteoporosis. Next slide. Preventive Services recommendations of the U.S. Preventive Services Task Force and the Women's Preventive Services Initiative are covered under provisions of the Patient Protection and Affordable Care Act of 2010, or the ACA. For most women, these services are provided with no copay or deductible charges. Recommendations are based on evidence of effectiveness and the balance of benefits and harms. These determinations are based on research, much of it NIH-funded types of research. I've listed on the slide the links to these recommendations if you'd like to take a closer look. We'll examine a couple of these in more detail. Next slide. The effectiveness of screening and prevention depends on completing multiple steps in the preventive services pathway, as diagrammed here. In order to begin, women require access to health care, indicated at the far left side of this slide. They then need to be correctly identified as eligible for a service based on age, risk factors, other considerations depending on the service, and then successfully undergo screening or the preventive service. If screened positive, for example, they then need to successfully move on to the steps of follow-up testing, such as a repeat image or mammography screening, and then on to diagnosis, often including a biopsy, and on to treatment. If indeed they screen negative or have a normal response to screening questions, they then move into perhaps periodic screening. Much of the preventive services provided through those recommendations involve repeated screening, perhaps in a few years down the line or in the next encounter. They need to successfully be cycled back into the screening pathway again. All of these steps are influenced by factors outside the pathway relating to societal, health system, clinical, and patient level variables. All components of this pathway and all these levels of influence determine whether screening and prevention are beneficial or harmful. It's important to keep this image in mind as we go through some examples in the rest of this talk. Next slide. Currently, there are many research gaps in the preventive service pathway that limit our clinical recommendations. Research relevant to screening and prevention primarily focuses on mechanisms of disease, epidemiologic associations, technologies for screening and diagnostic tests, and treatment of conditions once they are identified. These are important areas, but there still are evidence gaps where research is lacking. We have a need for randomized trials of the effectiveness of preventive services on actually improving health outcomes. It wasn't until the Women's Health Initiative trials that we finally learned that menopausal hormone therapy does not prevent chronic conditions in women. In fact, it can cause harm. We need research in clinically relevant risk prediction methods, since many of the screening and prevention services depend on understanding an individual's risk. Currently, those risk prediction methods are inadequate in general. We also need to understand the barriers and facilitators of implementation in different populations. We'll examine that in more detail here in the next few minutes. We also need to understand the harms of screening and preventive services, which include false positives, false negative tests, and complications of procedures. It's important not to cause problems for patients while trying to prevent them. To better illustrate these needs, I'll describe two examples of research that can help fill these evidence gaps. Next slide. Our first example of how to address these types of evidence gaps considers cancer screening in women. This graph illustrated estimated cases of cervical, colorectal, lung, and breast cancer. These are the 4 types of cancers for which screening is effective at reducing cancer death. The orange bars indicate incidence, and the black bars death. As you can see, breast cancer has the highest incidence rate of these 4 types of cancers, But lung cancer has the highest death rate. These are specific rates for women. So even though we may not consider lung cancer as importantly as breast cancer in sort of day-to-day media, lung cancer is a higher cause of death for cancer. Next slide. Currently, there are 4 recommendations for preventive services for cancer screening that are specific to women. These include 3 specific for breast cancer screening. These include breast cancer screening, mammography screening every 2 years for ages 50 and older and starting at age 40 as indicated by individual factors. Risk assessment, genetic counseling, and genetic testing for women with family history suggesting possible gene mutations. Medications to reduce risk for breast cancer for women at increased risk for breast cancer, but at low risk for adverse effects of these medications. And cervical cancer screening, beginning at age 21 to 65, and the intervals depending on the type of test given. There are lots of details and innuendos about risks and intervals, types of tests that are better covered in the more detailed descriptions of these services. But many of you are familiar as you've undergone many of these tests yourself. Next slide. There are also preventive services that are recommended for cancer that are not specific to women, but actually affect women as well, including colorectal cancer screening, beginning at age 45 to 75 years, lung cancer screening for women with a 20-pack-year history of smoking, who currently smoke or have quit within the last 15 years, and tobacco smoking cessation. Overall, if you add these up, we have 7 recommendations for cancer prevention and screening that have proven to be effective at reducing cancer incidence and death. Most of these require screening technologies and treatments that have been extensively studied, and this research has contributed greatly to decreasing cancer morbidity and mortality. Next slide. However, despite these efforts, underutilization limits the impact of these services. There are low rates of lung cancer screening and a lack of data specific to women. There's low uptake in practice, particularly for assessment of family history of breast cancer and appropriate referrals for genetic counseling and mutation testing for women at risk. Most often, the women undergoing genetic testing are not the women who actually need it. There's low uptake and use of medications to reduce breast cancer risk among women at increased risk, and low uptake of smoking cessation practices. Next slide. We also have important differences in cancer screening based on other types of disparities. Recent data from the National Health Interview Survey describes differences in screening rates for women based on several factors. The biggest differences across demographic groups are related to income. In this graph, we see along one side the percentage of women who have been screened for different types of cancers, including colorectal cancer, breast cancer, and cervical cancer. Notice we have no data on lung cancer screening. The dark bars are the screening rates for women who have an income at 200% or more above the poverty level. And the light bars are for women below this level. As you can see, screening rates vary widely depending on which bar you belong in. And the rates for no screening at all are highest among women with the low income category. So despite coverage of screening as a preventive service mandate, disparities exist that relate to income. Similar differences were also demonstrated for insured versus uninsured status. Next slide. By using the prevention pathway diagram I showed earlier, we can target research specifically to the evidence gaps. In this example of cancer screening disparities, research to fill the gap includes trials of methods to increase screening rates. Our research group evaluated trials that compared patient navigation services with usual care in populations experiencing health disparities for an NIH Pathways to Prevention workshop on achieving health equity in preventive services. Navigation services were tailored to meet the needs of patients to overcome barriers to screening. These included multiple components that varied by the type of navigation study, but generally included education, help with scheduling, transportation, assistance with referrals, and reminders for different types of screening tests. Next slide. When we looked at these studies, we found that trials of patient navigation compared with usual care indicated higher screening rates with navigation. The results indicated on this slide are for breast cancer screening. There were 10 trials included in this analysis, and they generally all showed increased screening rates for women who had patient navigation services versus usual care. Usual care certainly varies across different systems. Some actually adapt fairly supportive navigation type services as a matter of course, but most do not. These studies enrolled women predominantly of low income, indicated by the symbol LI in some of these studies in the table, and separated patients by those who had had screening at baseline and those who really hadn't had screening when they entered the study. We see that the effects were important for both types of patients, but particularly were highest among those who hadn't entered screening at all, as indicated by the dots on the graph at the top part of this graph. For those unfamiliar with forest plots, what we see here are a series of dots and diamonds that are on the far end of this diagram. This indicates increased screening rates with navigation compared to control groups. Similar results were found for colorectal and cancer screening trials, that among the low income and considered patients with disadvantages to screening, we found that navigation services improved screening rates. And while patient navigation services are not the answer to all issues regarding screening disparities, this research is a good example of the types of research needed to address them. Often solutions are more practical than technical, and research needs to support these studies as well. As you can see, many of the studies included in this analysis were rather small. They all had different types of interventions, different types of designs, and despite all that variance, they had the same results, which is only served to strengthen the results. So studies like this are very important to figure out how do we actually get people to screen. Next slide. Our second example of how to address evidence gaps considers another set of problems: depression, anxiety, and violence in women. Unfortunately, these conditions are common in women and occur at much higher levels than in men. As indicated on this slide, current rates include levels of interpersonal violence over 30% of women, depression at over 20% of women, and anxiety up to 40%. However, the high rates captured in this graph are likely underestimates, because all of these conditions are typically not diagnosed and are frequently underreported. Many researchers would double these values and contend that many women in our US American healthcare system are silently suffering from these conditions. Next slide. Currently, there are 3 preventive services to identify depression, anxiety, and violence. These include screening for depression, including pregnant and postpartum women, and referring for appropriate therapy; screening for anxiety in adults and adolescent women, including pregnant and postpartum women, also referring for appropriate therapy. And for both of these, appropriate therapy includes behavioral therapies as well as medical therapies as needed, and intimate partner violence screening, and providing and referring women who screen positive to ongoing support services. These screenings and referrals are actually covered under the ACA mandate, as I mentioned earlier. Recommendations for screening are based on research showing that detecting and treating these conditions improves them. And so these unaddressed health conditions unfortunately continue to be problematic when we can't actually find them and treat them. Next slide. Depression, anxiety, and intimate partner violence are often not addressed in healthcare. While intimate partner violence can cause physical injuries, it also leads to other serious conditions, and these conditions may actually serve as their primary chronic manifestation. Identification of one condition can help detect another. Although in medicine, we often approach them one at a time, we should take a more holistic look at how these are connected. This slide illustrates how several conditions that could be linked to each other in various combinations for individual women. Addressing one condition should lead to addressing other conditions. And understanding these relationships, particularly as to how they manifest in women and how they affect them across the lifespan, is very important in actually treating them and improving chronic conditions for women. Next slide. Research can help us do this better. Studies can focus on development of accurate screening instruments to screen for both anxiety and depression, for example, such as the instrument listed in this slide. Studies can help us understand relationships between conditions in women, particularly regarding the effects of life changes, pregnancy, menopause, many other aspects of health that are unique to women. Studies can help us focus on ways to improve early detection and treatment to prevent the chronic course and comorbid conditions that impair women across their lifetimes. Notice how the 4-item patient health questionnaire listed on this slide for anxiety and depression in 4 questions can help identify women with anxiety or depression. These fit nicely into the course of healthcare and can trigger the kinds of referrals and treatments that women need, but are so often not included in healthcare. Next slide. Our approaches to screening and prevention can focus on each woman's health as interconnected conditions, as illustrated in a Women's Preventive Services Initiative Well Women chart. This chart summarizes prevention services that are recommended for each age group and have multiple footnotes relating to different types and levels of risk. Ideally, this chart will evolve as new research expands our capacity for even more effective screening and prevention services. Next slide. Prevention of chronic conditions in women depends on effective screening and prevention measures. We need to fill the many evidence gaps for screening and prevention with appropriate research. We know that screening and prevention reduce risks for chronic conditions common in women. We can identify evidence gaps that limit clinical prevention recommendations. We know that research improves screening and prevention in women, and the types of research that are typically outside the usual conditions are personalized approaches that address patient needs, and recognition of some of these interrelated conditions that are unique to women and help and their effects on health and the function across the lifespan. So I will close with this slide and recommend 2 areas for further research. Research that specifically targets prevention and services. Research that specifically targets prevention screening research to the gaps in the pathway. We can lay out those pathway for practically any condition and really find out what parts of it are gaps in research. And secondly, research can shift the focus from funding high-tech innovations that have low impact on preventing chronic conditions, to some of the low technical women-centered approaches to prevention that have a high impact. Women's health won't improve if they don't receive the services. So some of those aspects are very important. I'll stop at this point and see if we have questions.